Hi, Drew, and thank you for joining me today on the Dementia Dialogues. How are you?
I'm very well, thank you, Natalie. Thank you for having me.
No problem at all. Thank you for coming on. So, for the benefit of the listeners, could you introduce yourself before we dive into the conversation and a little bit of background and maybe what we're going to talk about today?
Absolutely. I'm the senior marketing officer for PainChek in the UK. My working career has all been around technology, specifically within social care. So, started out working for tech suppliers around sort of the EMR and care planning space. That's electronic medication administration records in care planning. And then it was about 5.5 years ago where I joined PainChek. So, kind of shifted over to more of the medical device side of things. Yeah, that's very much kind of been my background. What we'll be talking about today essentially is the importance, I guess, about being able to effectively identify pain for people that are living with dementia. I think it's a huge topic. I think there's a perspective where everyone can agree that it's important to make sure that someone's comfortable, but actually what we're seeing with working with different care providers in the UK is that by managing pain, not only are we ensuring that that person is comfortable, but actually we're seeing much broader positive outcomes for residents and people living with dementia as well. So that's kind of the top line.
Yeah, I'm excited to actually dive into the conversation because I met Tandeep, your colleague, at the care show in Leeds. So he was very enthused about PainChek and the app of PainChek, and I got very enthused about it as well. And I thought, yes, we need to get somebody on the podcast to talk about this because it's an absolute. I think it's fascinating. So yeah, let's talk about PainChek then. For those who may not be familiar with PainChek, can you give us a little bit of background about what it's about, what it sort of aims to solve? Well, yeah, that essentially.
Yeah, absolutely. Um, PainChek is a licensed medical device. That's really important to acknowledge at the start. So we have all sorts of data to back up the effectiveness of this system, and we can dive into that a little bit more as we
Mm-hmm.
go through. But essentially, yeah, we are a medical device for adults, so 18 years and over, who have a cognitive impairment. Now, obviously, dementia stretches a huge proportion of that cohort. So I would say around 95% of my time is focused around dementia. So um, we started out in the UK, to be honest, only a couple of months before I joined the company. So I've kind of been here since having one or two clients to now we're licensed across, I think it's around 40,000 residential aged care beds in the UK.
Wow.
So it's been quite the journey. But yeah, so essentially it's all around not only identifying when pain is present, but also quantifying that level of pain. So it's a digital app, essentially, like you would download any other app on your mobile device. So those who aren't in residential aged care might not be aware, but there's a lot of sort of care planning and other care systems which are enabled through app-based technologies. So recording when somebody's had a drink or has been, assisted to the bathroom or whatever. So, it's very common that carers have these devices on them already. And essentially, the way that it works is we've got six different, we call them domains, but essentially it's areas where we're looking for pain indicators, one of which being the face. So the face is actually a very clear way of identifying pain indicators. So unlike you and I could hit my shin on my desk here and put on a brave face and pretend that it never happened and hide that pain. But as dementia as a condition progresses, that ability to cover or what we call learned behaviors diminishes. So actually, for people living with dementia, the face is a very, very clear way of identifying some of these indicators of pain. So that's where the AI comes in. So as I said, it's an app. Basically, the product will open up the camera on the device. Now, it's important to note that it does not take pictures or videos. It merely just observes the face for a few seconds. So the AI in the background is looking for a sort of a mix of facial movements that we know through research are pain indicators. So that's the AI element. And I want to just stress that, we're not taking away that human interaction. The remaining five, they're all conducted by a caregiver or a carer
Mm-hmm.
in whichever setting. So that's the first element. The remaining ones are basically what we call binary based checklists. So historic pain assessment tools have been very subjective in their nature. They will ask a person to rate, let's say, on a scale of 0 to 4, how severe that person perceives this certain pain indicator. So, naturally, I might say, oh, that's a 3 out of 4. You might say that's a 2 out of 4 for whoever it is that we're assessing. So by transitioning over to a binary-based checklist, which is literally just a list of pain indicators, and you toggle which ones are either present or absent, it really drives down that subjectivity and kind of standardizes the outcome and the consistency of the assessments.
Can you give an example of what that might look like, that binary?
Sure. So one of the domains, for example, is behavior. So it could be you'll have in that checklist, let's say, confusion or agitation or pacing, for example. So that's where the kind of it's really clear whether somebody is or is not exhibiting these different pain indicators.
It's a yes or a no in that case.
Exactly. It's not a yes, but it's a 3 out of 4, or yes, so it's that's where it really drives down that subjectivity. So there's over 40 different pain indicators across the entire assessment, essentially. And then once the various domains have been completed, so you've got face, voice, behavior, movement, body, and activity. That's the 6 in total. Once the AI has done the facial element, the caregiver has done the remaining 5, where you just go through these checklists and say yes, no, yes, no, yes, no. The system, you say save assessment. The system will add up the indicators that have been identified. It will add them all together, and then it will categorize that into no pain, mild, moderate, or severe. So the sort of analogy that I like to use is that PainChek is somewhat like a blood pressure monitor in its medical device nature, in that it will give you a result, but it won't tell you why that result. So it won't say, you've got high blood pressure because you've got a heart condition, for example. It just gives you a reading, and it's likewise with PainChek. So it still relies on that sort of clinical investigation.
Yeah.
Essentially.
Yeah. What's the time scale then for a care worker then to complete the rest of that checklist? Once the AI has done its analysis, in fact, how long does that take?
So start to finish for the whole thing is 2 minutes, is what we're seeing. I've been working with a care provider, in fact, just this week, who they've brought PainChek into a couple of their homes, not all of them. They've been able to evidence that it's taking around 2 minutes to complete the PainChek assessment. But in the other homes, the carers are having to go to the office. They're having to print out a paper-based assessment. They're having to go to wherever the resident is, at the point of care, observe them, complete the assessment, go back to the office, scan it in, making sure that all the data is added into the relevant parts of their digital systems. They're reporting that it can take up to an hour to complete a paper-based assessment.
And again, those paper-based assessments in that comparison, are they more subjective questions as well again?
Absolutely. So like I say, the outcome of a paper-based pain assessment for the same resident but with different assessors, it's very unlikely to come out with the same result. So you've got it's not just about time saving. Of course, our main priority and our mission as a company is to give a voice to people who can't self-report their pain. That's the crux of it. But actually, there's huge benefits as well for caregivers.
So you touched on AI there as well, which is at the forefront of every conversation everywhere at the minute, isn't it? And I'm embracing it, like it's making my life so much easier. How is, I know you're talking about PainChek using that for that initial facial recognition. Can you talk to me a little bit more about how it's doing that, how it's assessing that pain?
Absolutely. So basically, there is a body of research called the Facial Action Coding System, which has documented all the different muscular movements within the face. Now, our co-founders, who are academics, they're both professors actually, have looked at various different research and have kind of come up with the perfect recipe, really, around which of those are the true pain indicators. So the system, it's not machine learning, if you like. It's not understanding, oh, this person's face moves in this way or that way. Basically, all it's doing is it's looking at the face, it's identifying key markers on the face. That would be corners of lips, around the nose, your eyebrows, all those sorts of areas, and just observing how they move during that time period. And the AI then is what's documenting, right, this movement that's associated with this facial action coding system, which we know from research is a pain indicator. So it's I think this is, and we might come onto this a bit later. AI is, as you say, a huge topic, and some are really embracing it. Obviously, there's a complete lack of kind of regulation around AI. There's a bit of skepticism. There's a bit of worry. What's it doing? What's it learning, etc. Really, PainChek is enabled by AI, but it's really a layer of AI just to assist the caregiver. It's not harvesting unnecessary data, or it's not machine learning. It's none of these sort of large language models that we're seeing with the likes of ChatGPT, etc.
Hmm. How have you come up against any challenges with any care homes when you're talking about AI there? Then and how are you dealing with that? Because like you say, not everybody's going to embrace it, are they? So how are you getting around that?
Absolutely. So there are times, absolutely, that we come across that. We have, for instance, there may be nurses that say, I've been doing this job for X number of years. I know when my residents are in pain, and of course, a prior knowledge of an individual is so important to providing care
Hmm.
for them. But the key with PainChek is it's an enabler, but also it upskills the staff that wouldn't otherwise be performing pain assessments. So we're training carers, we're training the people who are there spending the most time with residents. Nurses are rushed off their feet. They're focused
Hmm.
on doing med rounds and, whatever referrals or liaising with GPs, etc. But actually PainChek's upskilling and spreading that task across the whole workforce. So I think that's a real key, but also, some of our biggest advocates are nurses. That's the other thing that's really key. And I think once you sort of have the conversation, as we've done just now, and outlined, the AI is playing a role in this. It's not telling you what to do. It's not giving you the result without your input. Um, I think at that point, then we're able to kind of reduce some of that worry or concern. That tends to be the general way that it goes.
Yeah, I think it's about supporting those carers, and to say that, well, that's exactly it. It's there to support and run alongside you, and in the grand scheme of things, save you time,
Yeah.
which every nurse and caregiver will, I'm sure, be thankful for, won't they?
Absolutely. I was delivering a dementia workshop earlier this week with it was around 80 sort of home managers and deputy home managers, as well as leadership teams, etc. And one of the biggest challenges that they're coming across is that these managers, these people that have come into the sector, the social care sector, to make an improvement to people's lives, to care for people, are actually spending a huge amount of time doing paperwork. They're
Yeah.
kind of shut away in the office, not being able to be on the floor doing what they joined this sector to do. So, it's not just about, although it is the foundation, it's about improving the accuracy of pain assessments to therefore enable better care and better health outcomes for individuals. It's about giving more time back for those people to spend with residents doing meaningful activities, activities of daily living, which otherwise, or at the moment, they're not able to do because they're too tied up with, stacks and stacks of paperwork.
Yeah, absolutely. Can see that's a clear benefit, isn't it? That is the benefit, if nothing else.
Absolutely.
You touched previously on clinical studies and the research. Is there anything there that validates the effectiveness of PainChek then that you can tell us about?
So there is stacks of it.
Mm.
In fear of getting a percentage wrong, what I would do is really encourage people to go to our website. So that's www.paincheck.com. Within there, you'll find a landing page which holds all of our clinical evaluation data. But essentially, without going into specific figures, the validation or the evaluation of PainChek has found a very high degree of accuracy and specificity with the results. So yeah, I'll try not to delve too deep just in case I upset some of our
That's
scientific team,
absolutely
but
fine.
that we've got
I
loads of it.
appreciate
So
that.
please do head over to the website and check that out.
And that research and that clinical data, that's taken from care homes where PainChek is in place for you now.
So we have loads of data from care homes that are using it now around the
Hmm.
outcomes. Again, we've got a relatively new sort of a summary report on the website, which brings together all of the data that we've kind of found from various different projects from around the UK. So it's kind of a single, one-stop shop for understanding how providers are using it and what it's doing for them. So again, I would encourage that. But the validation data for the studies that I refer to was more of it's a requirement, obviously, because we are a medical device. We can't just give ourselves that rubber stamp. We have to be approved with the regulatory bodies, etc. So these were all studies taken place prior to PainChek being available on the market, obviously to ensure that it's safe, it's effective, and they were done in controlled environments. So yeah, they'll be a few years old now, some of them at least. Although I know that University College London has just, I think last week, published an independent evaluation into PainChek as well. So I don't have the reference to that on me, but maybe I can give it to you to pop in the show notes if that's of use.
We can pop that in the show notes. Absolutely. I bet you've got plenty of case studies though, and examples of where PainChek's improve the lives of people in the care home setting and improve well-being. Is there anything that you can share on that front?
Yes, absolutely. So one of the fantastic clients we've got at the moment, I've been working very closely with, they're a fantastic bunch, are at Dovehaven Care Home. So it's a care home group in the northwest of England. I believe they've got 23 homes. I've been working with a couple of their clinical leads who are actually some of those nurses that I referred to earlier, who are huge advocates of PainChek. They're absolutely wonderful. But in terms of what they have seen, so we have recorded a 67% reduction in severe pain being experienced across their entire estate with PainChek, a 42% reduction in moderate pain, and a 25% reduction in mild pain, which obviously within itself, in terms of somebody's comfort and quality of life, is so significant. But then if we take it a step sort of deeper than that, what they've seen by identifying pain, treating pain, therefore making that person comfortable, we've seen a 41% reduction in distress incidents. So imagine you're in a care home, you're in pain, you can't tell someone you're in pain, but just because you can't verbally communicate doesn't mean you can't communicate. You find other ways to do it, and that often does manifest itself into behaviors. So that's, there's a reduction in distress, but also because of that, there's been a 58% reduction in resident to resident altercations within that care home group, instances of hitting out another person, etc., which obviously then leads into safeguarding referrals. We're talking about time saving earlier. Goodness, think about how much time saved by that reduction in 58% reduction in resident to resident altercations. But also the other massive thing, which is so important, is they've had a overall 40% reduction in the use of benzodiazepine drugs. So for those who don't know, a benzodiazepine is often used as a way of responding to distress. It's essentially a sedative. So not only is that bad because you've not identified the root cause of that distress in the first place, but benzodiazepines are known to contribute to an increase in cognitive decline. We're talking about people living with dementia here. That is the last thing we want to encourage. It's also an immunosuppressant. There's a whole plethora of reasons why people shouldn't be on these drugs unless they absolutely have to. So I think that's kind of one snapshot, I guess, of a client. In other care providers as well, we're seeing reductions in falls. So obviously if someone's falling, or if there's fewer falls, then there's fewer injuries, there's fewer hospital admissions. We know that if someone's living with dementia and they get admitted to hospital, the duration of their stay is much longer than anyone else. And it's the last place we want them to be. We want this person to be back, being healthy, and back into the community where they can receive the care that they need in a more comfortable environment. So again, I referenced that sort of outcome summary report. It's on our website. We've actually got, if you go to the homepage of our website, there's a big pop-up where you can download that report, and we've got probably, 6 to 8 different clients or projects within that, which outlines the outcomes that they've had.
We will we'll pop the link on for that actually on the show notes as well, just to make it easily accessible for the listeners as well.
That'd be fantastic.
I'm assuming then that all those reductions that you've talked about there, and tell me if I'm wrong in my understanding, is the speed of implementation of identifying that person is in pain, therefore being able to act upon that and do something about it, rather than them, like rather than a caregiver observing a change in behaviour, which is just another way of them communicating that something is wrong, and that
Yeah.
time going on, and maybe a caregiver just thinking they are being difficult in inverted commas,
Yeah.
when actually they're just trying to get across that they're in pain. And it's about PainChek then reducing that time and getting something in place quicker. Is that right?
Absolutely. I think there's a few prongs to this. I think first of all there is, of course, having a tool in place which is quicker, more accurate, more effective to identify pain in the first place. Obviously, that's a huge thing. But I think there's this misconception that because again, someone quote unquote, because they've got dementia, it's
Mm-hmm.
just part of the course. That's just because of their dementia that this behavior has started to arise, or this there's been this change in behavior. So we really need to challenge that as a social care
Mm-hmm.
sector, but also as a wider, as a country. We need to be
Yeah.
talking about this more. We need to really be busting some of these myths about dementia. And I think that's the real key thing. We know that I'm thinking back to there was an article on BBC News quite a few years ago, but it found that something like 90% of antipsychotic drugs for people living with dementia were inappropriately prescribed.
Mm-hmm.
It's a shocking level. So we really need to challenge each other to say, right, this behavior has changed. This is, again, challenging behavior. But we need to understand at the end of the day, these behaviors are due to an unmet need. Now, that could be pain. We do know that a lot of the time it is pain, which is why we're seeing these results. But it's also just as valuable to be able to rule out pain. You do a pain assessment because you've seen these changes in behavior. Okay, they're not in pain. What is it? What is this
Yeah.
person not getting in their life which is causing this distress? So
Yeah.
I think it's all of our jobs to kind of be detectives in some case, and really get down to it. This person is not difficult. They are distressed for a very valid reason, and we need to work out what that reason is. Again, like I say, often it is pain, but sometimes it's not, which is just as valuable to be able to rule that out.
Absolutely. And you could open a whole conversation on its own around that. I think I used to work in schools, and children acting out, for
Hmm.
me, there's an underlying reason. They're not acting out because they are quote unquote bad. They're either not stimulated, overstimulated. There's something going on at home. There's always a reason.
Yeah,
So, and it's exactly the same with people living with dementia. I totally agree. We need to remove that word of challenging
yeah,
behavior or difficult behavior. It's just a different behavior, and let's
yeah.
try and understand why.
Or it's a distress response behavior. That's
Yeah.
the thing. So what is the distress? We need to get to the real nub of that issue. So
Yeah.
yeah.
Are there any plans to expand PainChek's capabilities or develop any new features?
Yes, absolutely. So, like I
Mhm.
say, when we came over to the UK, I don't know if I mentioned earlier, actually, we're originally an Australian company. So our headquarters is in Sydney, which I must profess has much nicer weather than here in Essex. But um, we were very lucky, I guess, in the UK, in that Australia kind of did a lot of the heavy lifting. So over the last sort of 5.5 years, our focus has been primarily into residential aged care, care homes, nursing homes, etc. We are making some adaptations to the products to better suit home care providers. So again, will be used by professionals, but in
Mhm.
the individual person's home, because we know that we need to keep people at home as long as we can. Really, that's the place where people are most comfortable. So it's really important that we serve that space. So that will be coming further into the summer this year, which is very
Oh, good.
exciting. And then we do have views as well, or plans in place to serve people who are, caring for a loved one at home. That perhaps they're not at the stage where they're getting professional care and, for unpaid carers
Mhm.
essentially. So that will be the other step. And then actually, I forgot to mention something that we're sort of working on now and is starting to be used is within hospitals as well. So as I mentioned earlier, people living with dementia that are admitted to hospital often spend a very long time there, maybe because it's difficult to find a placement in the community. Maybe it's
Mhm.
because they're struggling to get the medication right. So again, the same challenges faced within care homes is the same for hospitals, in that pain is difficult to not only identify but quantify. So yeah, like I say, work's going on to sort of serve that space. So we've kind of got pilot sites, we call them, or early adopters, whatever you like to call them. We've got one in Scotland, one in England, and one in Wales. So that work's taking place now. So yeah, lots of exciting stuff going on at the moment.
Sounds really exciting, actually. There's a lot of questions coming in my head there. Cost wise, then I don't know if you can talk about cost from a. I'm just thinking from a care home business point of view,
Mhm.
comparing that to somebody that's trying to keep the parents in the home going forward. Is there any thoughts around that being sort of subscription based for a family caregiver compared to, well, or is the care home subscription based as well? How does that
Yeah.
work?
Yeah, so we contract licenses essentially to directly to care homes. So they pay a cost which is per facility, which kind of we work out on the number of people that they care for.
Yeah.
It's not expensive. It's sort of average is about £2.40 per person per month
Wow.
within a care home. It's not a huge amount of money. So that's the general price, but some care providers opt to sign a contract for 1 year. We've had some 3, 4, 5 year contracts signed. So really, it just kind of depends on more of a strategic direction for care
Yeah.
providers. I think
Yeah.
there's definitely a shift in the sector from with sort of traditional residential providers then shifting to more specialist dementia care. So they're looking for those tools to be able to keep people within the home for longer and better serve their needs. Um,
Hmm.
which again is actually an interesting one. I was speaking of another client who implemented PainChek around a year ago, and since PainChek's been used within their home, they've not had to have any residents leave their residential service to go to a nursing service elsewhere.
Amazing.
Whereas if you look at the same period a year prior to implementation, they had 8 people that had to leave. So
Wow, that's amazing.
it's really helping providers step up the level of acuity of care that they're able to provide as well.
Absolutely. Because it must be really difficult for somebody living with dementia to make that change as well. I always find in conversations, and personally speaking with Nan, I think with her changing settings a couple of times for one reason or another, I do believe that added to that deterioration of her condition. So to be able to keep them in that
Yeah.
environment that they're used to will be a massive win, won't it? That's
Absolutely.
amazing.
I think a continuity in care is important for everyone, but
Yeah,
especially for people living with dementia. It will
yeah,
be so distressing to be in a new environment with faces that you don't recognize,
yeah,
potentially not knowing actually where you are. So,
yeah.
if we can keep someone in the same place as long as possible whilst
Yeah.
meeting the needs that they have, it's a win for everyone.
And I'm not in obviously the care sector, as in I don't run a care home business, but going off that cost, if it's anywhere near that £2, whatever it was per resident, that's like in the grand scheme of things, that is nothing for the benefits that you're getting from it. I think that's amazing. I think that's you know
I would
well worth it.
I would, love to wholeheartedly agree with you, but I have to caveat that I do understand that, social care is so stretched and
Yeah,
underfunded. I appreciate that any additional cost is a huge decision to make, especially
yeah,
with the looming increase in employer national insurance contributions. But yes, look at how much
yeah,
a care home spends on window cleaners a month or on, you know,
yeah,
groceries or whatever. Proportionally,
yeah.
it's not a huge amount of money.
No, not in the grand scheme of things, maybe not. But as you say, we've got to appreciate the difficult times that they're in as well. So,
Yeah.
yeah, a point well made. A point well made. Have you experienced any unexpected challenges from care homes in getting them to adopt PainChek?
Um, I think. I wouldn't say there's been challenges, but I wouldn't say it's unique to PainChek. As I said earlier, I've worked across various different technology suppliers throughout my career, and I think especially when you're working with larger care home groups, the individual home managers perhaps were not a part of the decision-making process. It's kind of
Yeah.
been plonked on them as an additional thing to do, and that
Hmm.
can be challenging. And I completely empathize with that as well. You've been told, despite all of the other sort of struggles that you've got with workforce and this, that, and the other, that there's something else to do. So I think sometimes we come across issues where individual sites just don't want it. potentially. Like
Mhm.
I said earlier, you might have this perception that, we know our residents, we don't need this, X, Y, and Z, but that's not unique to PainChek. I've seen that across various different technology solutions that
Yeah.
we've implemented in care homes over the years. I think, and I touched on it earlier as well, this view sometimes from relatives that, pictures are being taken or videos are being taken of people, of their loved ones, of their relatives within care. But again, we can easily sort of support that with, an awareness poster on the front door. If you see a
Yeah.
carer using a phone, this is what it's for.
Yeah.
We've got I was up in Scotland last year doing a news feature for STV, the Scottish ITV,
Yeah.
and we had the husband of one of the residents that PainChek was being used on. He couldn't speak highly enough of it. He just thought it was a fantastic utility of AI within the social care setting. So, of course, everyone has different sort of views, but I don't think that there's anything uniquely challenging about PainChek. Once we've had that conversation, and again
Mhm.
reiterated, this is not taking away from caregiver judgment or anything like that, or clinical judgment. It really is just a helping hand.
Do they get the opportunity to trial it? Is that sort of maybe a way to get around any challenges? Can they trial it and see how it goes for a while, or is it a matter that they have to sort of sign up there and then and for the license for it?
So we have done and we do run a number of pilot projects with care providers. So what we try and do really is be a bit more consultative and understand what is it that they're trying to tackle here.
Hmm.
Some care providers say, look, distress is the thing that we really want to drive down. Some say it's falls, whatever. So we find this sort of strategy in terms
Yeah.
of how we best collect the data to kind of prove, I guess, that the product's doing what they want it to do.
Hmm.
So we do that. I would say the biggest challenge really, and it's the same with any technology, the outcomes that you get out of the tech is dependent on the inputs that go into it, right? So you need to
Yes.
make sure you're using it consistently. You need to make sure
Hmm.
you're using it properly. If you do those two things, you will find the results. And that's
Yeah.
essentially kind of why I put together this outcome summary report, is to provide that confidence that yes, we've got all the scientific data in the background. But this is what it really means in real terms.
Yeah.
So it's to kind of give that confidence. But yeah, the other thing I would say as well is that it does take time to collect that data. If we're doing correlations between outcomes and, an increase in the volume of assessments versus the decrease in levels of pain versus the decrease in the frequency of falls, etc., it will take, you know, 12 weeks minimum. So
Yeah.
I would say, look, we've done it a bunch of times. If you're bought into this, we can make it work. That would be my headline on that.
And they've always got that to look back on, haven't they? I was just thinking about once you've assessed a resident using PainChek, you've got that as a comparison then going forward forever, haven't you?
Hmm.
And equally, am I right in thinking that the records are sent to their GP from the app? Do I remember
So
that conversation with Tandeep, or not? Have I made that up?
the records, well, you're kind of there. The,
Kind of
the
there.
the outcomes of the assessments will feed in directly into the care planning software that care home is using. So that's really, really important that
Yeah.
the data is
Yeah.
there and available, so that when you're doing all sorts of interactions and recording daily care, you can see that pain data within that sort of single source of truth, is what we would call it. What we
Hmm.
can do, and it's hit and miss. It depends on the willingness of the GP. We've seen it being really
Okay.
successful in some cases, and not so successful in others. But yes, we can facilitate a shared care model where we provide a GP with login credentials and only show them the data that they need to see. Essentially,
Yeah.
with that, what you do also find with care homes in particular, though, is that the GPs actually, they visit the site, so
Yeah.
they're there in person. They can just have a
Yeah.
look at the data that the care providers have got, and we've got plenty of stories as well of where care providers have been able to get prescriptions changed or optimized because of the pain data that they've been able to correlate. So we can do it. Whether or not the GPs are wanting to do it is, a different thing. Again, they've got lots on.
I just think, yeah, I know, yeah, everybody has, haven't they, in
Yeah,
that
haven't we
sort of
all?
sector. Um, I'm just thinking from a caregiver point of view, again, a number of conversations that come up is the caregiver having to repeat themselves about things that have happened
Hmm.
with the loved one. And if that is trying to get that, I want to use the word seamless, but it'd probably never be seamless, will it? But that clear communication across
Yeah,
different areas of the medical area is what I'm thinking
yeah.
of for that resident would just make things a lot better, wouldn't it? So if
You're
there
ab-
was just that willingness from the GPs or to take that on, it'd be amazing.
so I think there's another thing to highlight here as well, in that there's a requirement for care providers to retain all assessments for, I think it's 7 years. It's a huge amount of
Yeah,
time. So imagine if you're doing paper-based pain assessments for a resident, you've got to retain all of that paperwork, but each individual A4 sheet is an individual assessment. How you pull insights out of that is, it's completely impractical to suggest that it's going to happen in practice. Whereas with PainChek, one of the other massive benefits is not only the accuracy of the assessment outcome, but the documentation of that assessment as well. So you
yeah,
can go into the system, you can see the pain chart for that individual, you can see how it goes up and down over time. Obviously, you'd rather see it just doing a continuous decline, but
yeah,
if it goes up, okay, that's insight. Let's investigate that. Why has it gone
yeah.
up? So that's a real key thing. So from a documentation perspective, that is so important for getting GPs on side. You can't dispute the
Mm.
evidence when you can display it in such a way. The other really important thing is that we have, so as I said, the product is primarily app based and it's being used at the point of care. But we do have an analytics platform as well, which is desktop based. So you'd log into that on your browser. So what that will show a care home manager, or say if it's a large care group, a regional director, they can look at all these different pain metrics for an individual or for an individual care home or for their entire group or region, etc., and really break that down. And the other thing is we can look at individual people's pain profiles. So if I'm in pain, I will exhibit pain differently to you, Natalie.
Hmm.
I might shout and scream and run around and be really agitated and aggressive, and you could be the complete opposite and go much more introvert, spend more time in your room, not interact with people. So there's not one size fits all when it comes to people's pain experiences. So the more you use PainChek for individuals, the more the care teams are able to go, oh, that's interesting. Natalie's spending more time in her room today, but we know that that sometimes can be an early warning sign that she's in pain. Let's go and do a pain assessment and see what's changed. So
Yeah,
that's
it's
the
about
other sort of
spotting
level of
those,
detail.
yeah, spotting those patterns within it, isn't it? And probably a lot clearer using PainChek and being able to do that with a graph or than you say like 7 years worth of paper based going through the filing cabinet
Yeah,
trying to find that resident and put it all together would be so time consuming, where PainChek's going to give it more
yeah.
instantly, isn't it?
And that's assuming that those paper-based assessments were being completed in the first place. We know
Mm,
that they're cumbersome, they take ages, they're not always that accurate. So we were finding that they're often not being completed. Or if they are
yeah.
being completed, they're not being completed frequently enough. So that's the other
And then
key thing.
subjectively as well,
And
again,
yeah,
isn't it?
absolutely,
It's
absolutely.
just a massive thing, I think. Yeah. So, looking ahead, what do you think the future of pain assessment in dementia care looks like?
I,
Mhm.
for me personally, I think, without sounding too cheesy or a cliche, I think we're getting to the point now where we are offering the future of pain assessment and pain. You can't manage pain unless you can assess it, right? And we're that
Yeah.
first step in managing
Yeah.
pain. We're supporting people to assess it. So I think we've got a long way to go in getting more and more people using this, and I'm really passionate as well about getting it used in more settings. As we said, home care, hospital, and for unpaid carers as well. I think that's really important. Um, but I think we really need to challenge the status quo and have more of a general awareness of pain. Think pain. Whenever you see a behavior that changes, don't just go to the easy assumption that, oh, it's because of the dementia. Think what could be driving that change. We know that it is often pain. And like I said earlier, if it's not pain, it's just as valuable to have that insight so we can go looking at it for elsewhere. So I think really it's more of an attitude shift and an educational project, not only just for people within social care, but for all of society. I think we need to bust some of these myths. I think the other thing as well, sorry, going on a bit of a tangent here. I think
Go
there's
for it.
so much evidence and research and all this wonderful stuff around dementia, but I think that it over medicalizes this condition, this disease, and it's fantastic to have that. Don't get me wrong; it's so important to have this stuff, but I think that unintentionally dehumanizes dementia and the person. I think we really need to take a step back, think about that individual. What was their life history? What was their normal routine? What is it that makes them tick? And really provide that care for that individual in that way. And I think pain, it's a huge trigger for those instances of distress, and again, increase in falls, going into hospital, unnecessary
Hmm.
ambulance call outs, or maybe an ambulance wasn't called out when it needed to be. It really provides that extra level of insight and detail. So yeah, I think really we just need to challenge ourselves around how we think about pain, how we think about dementia, and ultimately, I think everyone benefits.
I am absolutely with you on all points off that tangent there. Completely taking that step back, and most definitely challenging ourselves. And that's certainly when I set out doing the podcast. I had sort of a vision in my head of not an end goal, of somewhere where what I'd like to see in the future. And the conversations that I've had have been amazing at challenging me in my own ideas and my own
Hmm.
perspective on it. And that's why the conversations are really important, so that we can all keep challenging each other and hopefully head in the right direction with it. So thank you
Absolutely.
for that. So if there was one thing you wish more people knew about pain management in dementia, what would that be?
Oh gosh, I think
Difficult.
it's so difficult. I think that the key is that there are so many areas of improvement and things to gain beyond just ensuring someone's comfort. Of course, that's so important. As I said earlier, it's a human right to have access to effective pain management, right? So we need to
Mhm.
check that box, because at the moment, I don't think we can say that there's that level of consistency for everyone
Yeah.
that's within care. We need to make sure that everyone gets access to that. But it's all the other gains that we get, that we said earlier, those different outcomes. It's huge. So don't see this as another thing to do. Another, oh, this takes me a couple of minutes and I've got to go around and I've got to assess X number of people. Think about how much time that's saving you as well, to be able to spend with that individual, which at the end of the day, if you're working in care, surely you've gone into it because you want to make a difference to people's lives.
Mhm.
You want to be having those meaningful activities and doing all the fun stuff, and not be doing all the paperwork and all the risk things in the background. So try and think about all the time that it can free up, in addition to the improvements of quality of life and quality of care given. But it's that meaningful time that you can spend with those people. So I think it's a very emotive subject. I'm very passionate about it, and I think we just need to think about pain more often.
Your passion, Drew, is absolutely evident in every single answer that you've given me today, to be honest. And yeah, I totally agree with that. That time saving, and then giving caregivers that opportunity to sit down and focus on connection
Yeah,
rather than a checklist of things, a million things to do, is so much more important. So much more important. So you're absolutely right. And just finally, then, if people want to find out more about PainChek, I know you mentioned it earlier, but how can they connect?
absolutely. So, by all means, connect with me personally on LinkedIn. So, my name's Drew Hunt. You can look me up there. We're also, PainChek is on all the socials, bar Instagram, really. So you can find us there, or paincheck.com is our website. You can find various case studies. If you fill in the contact us form, that will also come to me. So I'll be happy to connect with people that way. Or you can also email me at drew.hunt@paincheck.com. I should say the PainChek is not CK, it's just K on the end. So yeah, for anyone just listening in, you can reach me there as well.
And again, I'll put all those contact details in show notes as well. So all that's left to say is thank you very much for your time today. That's been a really interesting conversation. I am totally invested in PainChek and yet to find a negative for anybody to use it. And I can't wait for it to filter down through to those unpaid caregivers as well. So thank you very much for your time, Drew. Thank
Thank you,
you.
Natalie. Thanks a lot.
Thanks a lot.